We now move on to the next talk by Dr. Ramamurthy, tackling toric IL misalignment.
Thank you, Professor Titial, for including me in this nice course. The topic given to me is management of toric IOL misalignment. I'm going to be talking about factors affecting toric IOL alignment, the postoperative assessment, and in case this misaligned, how do you exactly realign? So to leverage the full potential of a toric intraocular lens, accurate alignment in the capsular bag is extremely critical, and any significant deviation from the intended axis deteriorates the visual function. It's well established that 1 degree of toric misalignment causes about a 3.3% reduction in the astigmatic correction, and rotation beyond 5 degrees is considered clinically relevant, and rotation of anything beyond 10 degrees needs surgical intervention. And the greater the amount of toricity in the lens, say 4 diopters or 4.5 diopters in the lens, the greater the propensity for misalignment to cause a residual astigmatism and need for realigning them. And one of the things that we need to understand that there is the greatest misalignment occurs during the first hour after surgery. And if you get the lens rightly positioned in the immediate post-operative period, very often in the after the first day, the post-operative rotation is less than 1%. This is one of the reasons that we keep our patients patched immediately after the toric IOL patients, even if they're done a topical anesthesia, patch for about an hour's time, keep them in the ward, and then see them after a couple of hours and then send them home. And we have not done a scientific study, but we feel that this might be one factors to lessen the chance of misalignment. And as far as the intraocular lens itself is concerned, there are modifications that have happened between the Technis Toric 1 and the Toric 2. All the features are exactly the same, except for the fact that in the Toric 2, the the frosted and squared haptics of the haptics have been changed. Essentially, what was done was when the entire optics and the haptics was polished, they just introduced some sleeves onto the haptics so that the haptics did not get polished. This was just a modification of the manufacturing process, and because they were left frosted, there's greater friction between the equatorial region of the capsular bag and the haptics, because of which the propensity for this to misalign is reduced in the immediate postoperative period, that is soon after the lens is placed in the eye. This also has a collateral advantage in the sense all of us know that the hydrophilic lenses, the haptic and the haptic, have the less amount of propensity to stick to each other. When in hydrophobic, there is greater tendency to stick, and sometimes we spend some time separating the haptics from the optics. Once you have the frosted haptics, the tendency for the haptics to stick onto the optics is also reduced, and they tend to unfold and go into the fornix of the equator quite faster. And because of this addition, again the tendency to shift might be reduced. As you can see over here, just a quick video to show you the frosted haptics and the intraocular lens being implanted, and you can see that these are roughened up, and I think slowly many companies are moving in this direction. And once you have this roughened edges and also squared edges, then the propensity for the lenses to rotate in the postoperative period is significantly reduced. And with these compared to the Toric 1, Technis Toric 1, the Toric 2, the 84% of the eyes were within 0.5 diopters of intended cylinder, and 98.5% of the eyes within 1 diopter of intended cylinder. And this, even more importantly, even in the larger eyes, like highly myopic eyes with even a 30 diopter lens, this stability of these lenses is well established, and axial rotation usually does not occur. It's not just the Technis Toric, but there are other platforms, even some Indian lenses like the iCryl, the fine vision lenses, and the Vivinex Toric. Actually, the Vivinex was one of the first lenses to come up with the Hoya platform, to come up with a roughened haptics. You can again see this roughened haptic. So whenever, as far as the stability of toricity is concerned, apart from other features, one aspect you could take into consideration is that if the haptics are roughened up, there is greater stability. Then the design of the haptics itself, you have the Acrisoft Toric. Actually, the reason the J&J went ahead and roughened up its haptics was it was established that their lenses, Toric lenses, had almost 3 times propensity to rotate compared to the Acrisoft. And the Acrisoft, though the haptics are not roughened up, the design of the haptic, the stable force haptics, where it functions something like a finger. So depending upon the size of the capsular bag, there is a propensity for it to unfold and be adherent to the capsular fornices. And the stickiness of the IOL material also provides further stability. We ourselves conducted a small study in the year 2022 to 2023. The Acrisoft IQ Toric, 615 implants, Hoya Vivinex Toric 265, and Technis Toric 2, 417. And what we found was that the amount of rotation was about 2% in the case of Acrisoft Toric, and cases which required a re-rotation in the post-operative period, while in Technis Toric 2 it was 0. This is significantly improved compared to our experience with the Technis Toric 1 itself. This is just to show you a published literature. From 5.7% in Technis Toric 1, it came down to 0.6%. Almost a 10 times reduction, simply because of the only change was the roughening of the haptics. In the case of an Acrisoft Toric, it's about 1/3, and this was one of the reasons why this modification of the haptics did happen. So in summary, as far as the design of the intraocular lenses is concerned, the rotation occurs most often within the first hour of implantation, and frosted haptics mitigates this because of greater friction, and design of the IOL also adds to the stability, as in the case of an Acrisoft IQ. The more sticky hydrophobic material also lessens the chance of rotation. This is just a toric intraocular lens being implanted with a digital overlay. I most often implant my lenses under just under irrigation. Do not use viscoelastic. But when you have a screw type injector, you have to use a viscoelastic in this case. And this is just as Professor Titial mentioned, you make sure that you have to rotate these lenses just in the clockwise manner. And once you have done that, you even after removing the speculum, please ensure that there is no shallowing of the AC and rotation of the intraocular lens. And these are some points during surgery that you need to keep in mind. A little longer incision so that they close more securely. Avoid overinflating, because if there is significant amount of saline around and behind the lens, just like viscoelastic, again the lens can rotate. Ensure complete visco removal. If possible, do a hydroimplantation of these lenses. At the end of the surgery, nudge the intraocular lens onto the posterior capsule so it sticks to it. Slightly smaller rexes, well-rounded rexes, so that at least there is a 0.5 millimeter regular overlap of the rexes onto the optics of the lens. Ensure that the position of the lens is stable even after the speculum is off. And if there is residual, then rotate after about 3 weeks. Of course, astigmatismfix.com as well as Barrett RX formula that can be used in case you have experienced a rotation of these lenses. Usually, unless it's a gross rotation which has been noted on the first post-operative day itself, I wait for a couple of weeks of time for the lens to, the capsule to fibrose a bit before taking up these patients for rotation. My favorite formula for this is the Barrett RX formula, which is available on the web, both at the ASCRS and APSCRS websites. This tells you what exactly is going to work, whether it's IOL rotation, IOL exchange, or piggyback lenses that is needed. Look at a situation like this. This is actually what we encountered in one of our cases. 24 diopter T4 intraocular lens being implanted, and the residual error was +1 with -2.5 diopters. One of the most important things you need to understand is that rotation of these lenses is going to help only if the spherical equivalent of the residual error is almost 0. Here, the spherical equivalent of 2.5 diopters of cylinder is 1.25, which corresponds to almost the spherical error that is there. If it is just -2 diopters of cylinder or just a +1.5 diopters of sphere, the rotation of the lens is not going to help, simply because by rotating the lens, you are not adding or taking away any power, but you are just realigning the power. So essentially, you have to understand that rotation will help only when the spherical equivalent is almost 0. In case there is this is shown for this particular lens itself, but in case it was not 0, I would go ahead and exchange the lens, and this formula will tell you what exactly should be the power of the intraocular lens that needs to go in. And in case the patient has presented to you after say 5-6 years of the initial surgery being done, and the capsule has completely fused down, wants this toricity to be addressed, then you can use this IOL exchange, the same formula, to tell you what should be the power of the piggyback lens that needs to go in. Now this is just to show you. So I think with this formula I am able to address all the concerns. As far as coming to some real life scenarios is concerned, case 1, most importantly, I always emphasize whether it's cataract surgery or refractive surgery, ask my optometrist not to go after those small powers if the patient is happy. It was a toric monofocal, so obviously there was a need for a presbyopic correction. But the patient has 6 by 7.5 diopters, and this was the refraction that was there. Patient was not complaining, and anyway I had to give glasses to that patient, so I just went ahead and prescribed the glasses with this, but most often he could function without glasses. So really don't go after that small cylinders if the patient doesn't have a problem. And in this particular case, even though the residual cylinder was just about minus 0.75 in 130 degrees, the patient was extremely unhappy because she had just about a 615 uncorrected visual acuity. And then we suggested that we could do the right eye surgery and then take up the left eye for rotation if she was not so comfortable. But then she insisted on the left eye being taken care of. As I said, it's simple astigmatism. We went ahead and did a PRK for this particular patient, and it worked out very well. And this was a case of a resume which I had implanted way back in 2003. She underwent bilaterally for a development cataract at the age of 10. YAG capsulotomy was done in 2015 for a PCO in one eye. And she had settled down in the US, and at the age of around 31, she came back regularly. She used to follow up with us during our visits. She had about -2 diopters of astigmatism left over, as you can see. And at this point of time, she wanted that to be addressed. So the surgery had been done almost 20 years back. And essentially what we are doing here is to put a piggyback toric intraocular lens in place, so that it was just a minor amount of astigmatism, but because the cornea was not appropriate, the TBI was almost 1 in both the eyes, we could not do a laser vision correction. So this is a toric piggyback lens that's being implanted to take care of the residual astigmatism. We did not consider rotation or anything because this surgery had been done almost 20 years back, and it would have been very difficult to rotate this lens. And just in case this was the postoperative outcome in this patient, we implanted the lens in both eyes 2 days apart. It was a very comfortable patient. And when you have a situation like this, is what was alluding to, 1.5 diopters with -2 diopters a cylinder, and the uncorrected visual acuity is 6 by 12, obviously a very dissatisfied patient, and she had received I think a continuous range of vision toric intraocular lens. This is what you see over here. So basically there was a significant misalignment, and this is just to show you that the Barrett RX formula and the astigmatismfix.com almost function equally well in both these cases. Both of them show that there should be almost a 33-degree misalignment which has occurred, and obviously this needs to be taken care of, and this is exactly what we do. Basically you can see the lens should have been in this axis, but it is over here. We had waited for about 3 weeks, and you can see some amount of fibrosis, the capsule that's occurring, but still though it's a hydrophobic acrylic material, it has not got adherent. So I do not use any viscoelastic, but I just go in with a irrigation cannula, then with just using a Sinskey hook, separate out the capsular adhesion from the optics of the lens. Unfortunately, what's needed is just a little amount of with the rule clockwise rotation, and this is what is being done gently, and with the digital overlay in place, you can ensure that the alignment is as accurate as you want, and this was the final position. So basically toric intraocular lenses have come to stay, and I think many practices, almost 60 to 70% of our lenses are toric lenses, and once you understand these lenses completely and deal with any problem that arise out of them, you can give the optimal results. Thank you so much for your kind attention.
Thank you, Dr. Ramamurthy. Just one question. Sometimes, what we see, if you look at toric alignment, lens alignment, 3 dots are matching exactly onto the, your marker. Other 3 dots are not matching. Any trick in that?
Yeah, we do see that, and more often it's all 3 dots are matching, but they're not exactly in line with where you want it to be. As far as it's parallel to that line, then I do not mind. There are 2 boundaries that are set apart, and if it is within that, it's okay. And sometimes, especially with the Indian toric, sometimes I experience that the toricity does not exactly align. But I try my best, but if it doesn't, if it is within those boundaries that are there, I leave them behind. I think it's also because of maybe inappropriate marking or slight misalignment between the capsular back size and the overall cornea.
Okay, thank you.